Recording. Hello and welcome to this ARMA lecture, ARMA webinar, which we would like to thank all of our speakers today, but I'd also like to give thanks to Arthritis Action, who are partners in this, and it's the support of our partners that helps to keep the ARMA webinars free for you to access. Today's webinar is the most popular webinar we've ever done in terms of registrations. So we're really hoping that you will find this a useful and interesting webinar, and I really think you will, because we have three great speakers coming up. We have Dr. Ai Lyn Tan, who is a Parkrun ambassador as well as a rheumatologist. We have Hamish Reid from Moving Medicine, but we're going to start off with Sara Hazard from the Chartered Society of Physiotherapists, who have been doing their campaign, which you may have seen, which is their Love Activity campaign. So, but before we do that, we're going to just do a couple of polls. First of all, to find out who we have on the line. So if you can all just let us know who you are by voting in this poll, and then in a moment I will close it and post the results. We have quite a wide range, some patients, clinicians, various others. So I'm just going to give another few seconds for people to vote, and then I'll end that and share the results. So you can see other health services is the largest number, followed by clinicians, and then a range of other people and some patients. So this is probably, as well as being the most popular, the most wide-ranging type of registrations. We have had all sorts of people registering. But let's just see how you personally relate to physical activity. So adults are recommended to do 150 minutes of moderate activity per week and strength activity on 2 days a week. How much do you do? Be honest. We're getting quite a wide range of responses. It's pretty much even at the moment, other than inactive. Some honest people saying they're inactive, but most people are doing at least some. So I'm just going to finish that there and share the results. So the largest number of you are doing lots more than that, but actually quite a lot of you are doing less than that. So I think it is worth just reflecting as we go through this on what that means. So quite a lot of you, if you are clinicians trying to support people to be more active, are already doing far, far more than that, the recommended minimum. So you might need to do a bit of work to think about where the people you are working with are coming from. And then those of you who are doing a lot less than that, if you are trying to support people to be more active, might want to think a bit about what it is that prevents you from being as active as you know you should, while you're helping other people to do that. So I think that's just useful to bear in mind as we go through the webinar. But I'm now going to invite Sara to talk to us about the Chartered Society of Physios campaign. I'm just going to launch that presentation. And over to you, Sara.
Great. So as Sue said, I'm from the Chartered Society of Physiotherapy, and I'm the Assistant Director of Strategic Comms, Communications, and I have the pleasure of having probably the best portfolio, at least as far as I'm concerned, which is to promote physiotherapy and the benefits of physiotherapy, the profession itself. So I just want to talk a bit about the background to the campaign and tell the sort of story behind it and how we got there, because it's quite important. So next slide, please.
Carry on talking. It will
Okay.
move.
So we did a little bit of, and you can actually, it can go 2 slides forward. So once you get to the next one.
Yeah, I'm going to unshare it and reshare it. Carry on talking, sorry.
Yeah. Carry on talking amongst myself. So we did a bit of sort of background research, polling to just understand the sort of context that we're operating in terms of people with long-term conditions. And we were able to identify that 20% said that the advice that they were given made them feel that they were being told off. And 40% have never been given advice by a health professional on how to be more active. So the advice they may have been getting might have been very concise, but it wasn't sort of on the broader piece of sort of physical activity. And at the same time, at the Chartered Society of Physiotherapy, we were trying to figure out what it is that was really sort of important about the role, what physiotherapists and the profession could do in terms of public health, where in that space we could add value. And so we did quite a bit of research into that. And so that research was condensed into about 200 pages of research, condensed into about 3 pictures, which might launch at this point. You can go to slide 4, actually. Perfect. So really interesting. We talked with sort of physiotherapists in the top profession, and we said, what's that sort of thing that's quite unique to that whole kind of public health space? And they said a lot about what we shouldn't do. So don't call exercise. When I tell my patients exercise, they don't want to do it. Don't call it public health because people don't know what you're talking about. And if we go to the next slide, what the professionals helped us identify was that it's people with a long-term condition or more than one long-term condition who basically have a barrier to physical activity. Next slide, please. So again, we did another sort of 100 pages worth of research with the people that we would classify as quite active members. So they were actively promoting the campaigns that we had active at that time. Had been active for several years. I think one of them worked out at work for about 7 years at that point. And we said, we want to keep you engaged. What do you need from a campaign? And I guess for the clinicians listening in, this probably wouldn't be a great surprise. They said, keep it fun, keep it simple. I've got 1 to 8 hours that I can do. Is it something I can do in my consultation? Can I sell it up to my manager? So this isn't just a kind of physio vanity project, but this is something that is about the broader outcomes that we're trying to achieve. So next slide, please. Because this, that slide is missing, but that's okay. So we created some ideas to test with the public. And there was a list of, maybe that's that one. Perfect, thank you. And this is really interesting because this is a real lesson to us as creatives and comms people about how we fell into the trap that almost everybody that preceded us did, even though we did all this background research with the professionals. And that's because we thought we were incredibly clever. We came up with a load of messages that were really clever. We patted ourselves on the back and we thought, oh, well, the public is probably, they're probably going to fall over at least 3 of them. And our most difficult decision will be which one will we choose? And basically we tested these. And I mean, on some of them, they positively told us where we could go. So, and some that were actually, I thought were quite benign, really insulted people. So it was a very important exercise, both in learning humility as a professional, but also in really understanding that if we were going to not fall into that trap, we had to work a lot harder and we had to listen to the patient voice. So next slide, please. All wasn't lost. When we went into this, we knew roughly that, and obviously we sell to everyone in a sort of marketing terms, even the NHS bit, as physios, but we were really focusing this kind of marketing at sort of people in the 40 to 70s audience, but who have, like I say, a long-term condition or more than one condition. But clearly this is not a homogenous audience. And what was clear is that the main drivers, fear of pain, came out loud and clear. But actually there were different groups within this. Men and women answered the kinds of focus groups very differently. And there were kind of warriors, can-doers, and confidence. And that was quite important because I think we realized we wanted to reach the vast majority of warriors, almost all the can-doers, and the sort of bottom edge of that, of those confidence. So next slide, please. Is that cooperating? The next slide?
Keep talking, it'll get there, I hope.
I'll keep talking. So one of the things that was quite interesting was if we think back to when we first spoke to those physios, when we mentioned things like, are you sort of, are you trusted advisors? Are you reassurers? And physios talked in that language, but as soon as we played it back to them, they were really hesitant about owning that, almost like it was a bit smug to do that. Well, what was interesting was the public had no problem with that, and they were very clear that to them the role of physios were as advisors, reassurers, referrers, and pain relievers. And that was very helpful because it meant that we could go out with a genuine message if we were sympathetic and showed empathy, and we didn't have to try and prove something that really just had to try and exist in a believability gap. So if we go to the next slide, we really at this point actually were a bit more clever now as comms people, because we knew a lot more, because we asked the experts, the patients, and we knew that the campaign had to do these things. And I'm not going to repeat them, so we could go to the next slide. Because the next slide is going to show you what we went back out with. And this time we did have two campaigns that the patient group thought we could use. And so because we had two usable propositions, and you may notice that in the first campaign, what was interesting was we tested the proposition, hate exercise, love activity with no connotations. And one of the reasons that was sort of half and half. It didn't completely fail as the other ideas did. But there was real division, and that was because leading with hate felt very negative to people struggling with LTCs. So when we went back out, we turned it into a question proposition, and we put it second. That made creating the strapline much harder from a creative point of view, but it resonated more. And then the gently does it also resonated. So we went back to the physios and we said, we've got two propositions. What do you think we should go with? And although you can imagine physios really struggled kind of notionally with the words hate and exercise next to each other, they got it. And they got it because it's what they see in their consultations, and it's what they told us. So if we forward to the next slide, we created a look, as any campaign would have. We created, obviously, the kind of the kind of proposition we were offering from it. And then we realized our first main job, actually, although this was a public campaign, was going to be to get some common understanding amongst the physio audience about what we meant and what this meant all of the role of the profession was going to be. So if we go to the next slide, this was the first piece of content. So this went out in the pre-launch period.
There's a lot of power in a conversation. We all have stuff we'd like to change. Drinking less alcohol, eating more of the good stuff, or stopping smoking. Except we often don't change. We stick with the status quo. Why? We often think of ourselves as one thing, us. The reality is we're often conflicted. The logical us knows changing habits is a good thing, but the emotional us can be resistant to change. And for us to change behavior, we need a powerful motivator. For some, it takes a scare, like cancer, a heart attack, or a stroke, before they are motivated to change. For others, luckily there's also a far less dramatic, although equally powerful way of gaining motivation: a conversation. As physios, we don't always have the conversations that can make a difference, because things get in the way. Not having enough time, not knowing what to say, thinking it's not our business, etc. As the expert, you hold so much potential to motivate change, because your patients trust and respect your advice, no matter how rushed or awkward you think that conversation might feel. The chances are it could be just the nudge they need to kickstart healthier habits and avoid less desirable outcomes. Of course, being on top of the guidance and knowing your numbers can also give you more confidence in these conversations. Together, across the millions of contacts we have each year, we can help to shape public health for the better. One conversation at a time. Join us and be part of CSP's new public health campaign. Visit www.csp.org.uk/activity.
So just in the interest of time, I'm going to really rush through the last bit. So this is content. And there are 4 other videos that we created with the campaign at various stages, and we can forward again to some of the results. But I mean, today we just released another piece of content called Never Too Late. It's a Christmas film. And again, it comes off the campaign and the idea of sort of how important the rehab and strengthening for patients is. So these are the results. And this is, this tells us a bit about the kind of the reach. 2,100 physio practices signed up. This was the most popular and taken up campaign ever for us, which means that they adopted this sort of into practice of how they would work with patients. And then the next slide tells us how we do this locally. And again, the take up. So real different approach. And obviously the next slide is how clinicians can get involved. And that's, I think,
Great.
last, there's one more slide that's there, and that's from me.
There we go. Great. Thank you very much, Sarah. That's been really helpful, I think, particularly in terms of setting the context and some of the background and the research that you've done. So now I would like to invite Hamish Reid to talk to us about the Moving Medicine resource, which is another resource which can be used by clinicians to discuss this sort of thing with patients.
Thank you, Sue. So I'm just going to look to share my screen now. With a bit of luck. That's going to share. So can I get a nod from the panelists if you can see that?
Yeah.
That's great, thanks. Okay. So first of all, thanks everybody very much for tuning in. My name's Hamish Reid. I'm a consultant in sport and exercise medicine and have been involved in the design and development of Moving Medicine, which is a project led by the Faculty of Sport and Exercise Medicine in collaboration with Public Health England. Now, I thought I'd just start by giving a brief context of the work here, and it follows on really nicely from Sarah and the work they've been doing in the CSP. So the brief for this bit of work was to consolidate the evidence base for physical activity in the context of specific clinical conditions and develop it into clinician-facing resources. So the resources that we've developed in movement medicine are specifically focused at clinicians themselves and designed to be useful and to start helping, trying to change the context of how we're talking to people about physical activity or long-term conditions. I thought I'd just sort of recap on how this fits into the sort of population physical activity agenda, and just reinforce the fact of how important it is that we do address this in healthcare. So I'm not sure how many of people signed in will be familiar with this wheel here, but this is the 7 best investments in physical activity that have been shown to be the best ways to approach change to population inactivity, of which we are really struggling at the moment in the UK. So health and health education is right there in the middle of it all. The reason that I kind of feel that this is so important is that there's a particular group of the population that actually is very hard traditionally to access. We're trying to with population physical activity initiatives, particularly from the activity sector. And this is because people with low activity are, as we know, at higher risk of getting disease. When they get disease, we know that they become less active again. And it's a vicious cycle that puts these people a long way from the reach of other initiatives really that have been going so far. So with healthcare, actually, these people, because of the disease, is what brings them into contact with our services. So we have a really unique access point to some of the least active members of our society. And it's these least active people that really will benefit the most from just very small increases in their activity. As we know, there's a huge burden in the UK. Our inactivity levels and mortality directly related to physical activity are very high compared to countries in the world. I think we rank 126th out of 147 in the Global Observatory for Physical Activity in terms of our inactivity levels. So we've really got a long way to go in the UK. The context of this in the healthcare system is that we're all working in this legacy of rest. So we kind of have this Victorian agenda, really, that if we have an illness and a disease, then our sort of default response in healthcare and society is to rest until we get better. And whilst that was something with infectious disease and things like that, actually, in the context of our huge non-communicable disease burden, really this is all this is doing is making things worse. So this is a big challenge right at the root of what we believe as a society about what we should be doing when we have long-term conditions. Now, as Sarah mentioned, and I'm really pleased, Sarah, that you chose that particular video to show today that focuses on the conversations, because for us, the interface really between healthcare and the population is conversations. It's the conversations that as clinicians we're having every day in practice. And there are probably three main components to good quality conversations with physical activity. One is some things about physical activity and some understanding about that. But also we need some specialist knowledge regarding advising people with long-term conditions to help them overcome some of their fears, concerns, and also important things about, how you might manage your blood sugars if you're diabetic and things like that. And, if you're doing activity. But as well as that, if we neglect the behavioral change component, then we're really going to struggle to make an effective change. When we reflect on how we're looking in the NHS and healthcare system as a whole, actually we fall down on a few of these things, because traditionally we haven't learned about physical activity in medical curricula, and there's lots of efforts going into trying to address that at the moment. But it isn't something that we're strong at in terms of our knowledge. In terms of our skills, actually our behavior change skills are quite limited as well, because that's not something that traditionally we've learned well either. And in terms of our systems, tied in there with the legacy of rest, our systems, basically we've been working to streamline the NHS and to cut as much sort of chaff and contact time out as we can. So actually a lot of the opportunities that we used to have to try and change physical activity behaviors have kind of been removed from the system. So there's all these things coming together that are making it hard for people working clinical practice to start making a change for their patients. Now, I thought at this stage, I'll just show you an introductory video from Moving Medicine, just to give you a brief context of kind of where we are with the project. So I'll just get started. Oh, hang on. I'll just start that for you. Great, and there's our dancing doctor at the end. So that's the introduction to the resources. Oh, hang on. And in terms of how we've got here and developed it, the key part that I'm going to introduce you to today is the prescribing movement resources. Moving medicine as a whole will bring on some further components later on, but this is the key part of the work that we've been doing over the last year. And we've been using a knowledge into action cycle to try to funnel down the evidence around physical activity in the different areas. And then we put a lot of work and a lot of consultation phase into developing a mechanism that's actually going to support clinical practice. So there's lots of places that you can go to find out sort of long form information about physical activity in long-term conditions, but we wanted to make something that was really useful. We've involved over 300 people in developing the resources and collaborated with many different partners, which has given enormous value to the project and really shaped how it's developed. And it's been a kind of iterative phase of development. Now, I'm actually going to take you out of the presentation now. I thought we could just go straight to the website and I'll just show you it. And if you have the capacity to do this at the same time, I'd encourage you to open up movingmedicine.ac.uk. You can see at the top of my screen there, the website. We've got our dancing doc and the video at the top. There's some how to use and various other links, but I'll take you to prescribing movement, and we're here to talk about MSK pain today.
So we've still got your presentation on the screen.
Oh,
and I think you might have not stopped sharing it.
Does it not just show my screen?
You need to stop sharing.
Okay, sorry everybody.
Yeah, now you should be able to share the website.
Okay, so I thought it was just showing my screen. Okay, brilliant. Right, apologies for that, everyone. Okay, so you can see the website there, right? So, so here's the website, and you can see at the top there's the bar prescribing movement, and there's a how to use it just to familiarize you with it. But I'll just take you into it quickly. So you can see at the front here for MSK pain, the interface is kind of, because we recognize that the biggest barrier to talking about physical activity is time. So as clinicians, we're all pushed for time. And the important message for us is that you can have a really constructive conversation about physical activity in 1 minute, and you can have a really terrible conversation about physical activity in an hour. Okay, so in terms of how we're influencing people, we need to try and maximize the impact that we have in the different phases. So in the 1 minute conversation, if you to go into this, so it's just loading up. It's just 3 points really that we want people to say, to find people, to ask people what they know, and do they know that many people find it moving more really helpful, and explaining that's something that can help take control of your condition and help manage your pain in the long term. And then invite and signpost people, and really just a really simple interaction like that, to bring it up in their agenda, and also give some information to them. So you can see on the top right there's an information for patients. That's got some printouts and a worksheet. So there's a condition about being active and for your musculoskeletal pain. There's talking through some top tips and things like that. Now I'll take you into the more minutes conversation here. 5 minutes is, if you like, a sort of cut down version of that. And I'll just talk you through the steps briefly. So we've hung, if you like, the resource in motivational interviewing theory. So you'll find that as you go through it, there's a kind of an envelope of the conversation of a good quality consultation. But within that, there's the specific details related to musculoskeletal pain. So I'll just show you here and ask permission. So let's start by asking permission. So we need to step away from telling people what we want them to do. And so you go into the pop-up boxes, and there's just a little bit about you know, elaborating really why it's so important that we start framing our conversations in a person-centered way. Because ultimately, it's the plan of an individual that's gonna be the important thing, rather than our plan as clinicians. And as we go through then to explore benefits, what we've done here is go through all the different sort of subsections, important subsections of musculoskeletal pain. So here we've got osteoarthritis, and you can see it reduces pain. But what we've done to make this easy and accessible is have that in the front. But if you click on the information through, then you can start to find evidence summaries and grading statements and things like that for all of these different evidence statements. And there's prevention as well. And you can see here, so the steps of the conversation are asking for things like reflection. You go in there and giving people a bit of space and asking if they can understand. So all to do with building their own motivation towards things. At the bottom, there's some links to good guidelines, for instance, the ARSI guidelines here, and then EULA recommendations. So links through to all of these things. The concerns were a big thing that came out through consultation with patients and clinical staff. And the way that we've tried to frame this is to think about the things that people talk about and commonly come to clinicians that people feel difficult to answer. So I'll take you, for instance, to this one. I've been told that my scan shows damage. I don't want to make that worse. So what we've done here is try and get some answers, so how we can start replying to people to have constructive answers about these common questions that we face in clinical practice, and also links to references where you can find more. So this is to try and help give people the language and confidence to start answering these difficult barriers that people have to physical activity. So building readiness is a really important thing in here, and from an MI point of view, we've got things like confidence scaling and building the readiness there. But it also in this we've developed cycles for the major symptoms that patients and clinicians have reported as barriers to musculoskeletal pain. So for instance, it's difficult to explain to people why physical activity is going to help their knee pain if their knee pain gets worse when they move. And it's the sort of conversation that we're all familiar with. But these cycles are there to show patients, hopefully help them understand kind of what the process is behind that, and fatigue and various other symptoms. And just moving through to the end, we've got sort of a time to agree a plan and see if people are on. Are they ready actually to start changing their behaviour? So that's the key step, you know. So number 2 here is that's the real thrust of it. Are they ready to do it? And if so, what plan are they interested in? With a key message about building activity into everyday life. And then in terms of where the plans are, there's 4 options of different plans here. So for instance, if we go into action planning, there are documents to support all these different plans that people can use, and you can give to your patients, things like goal setting and building up, making plans, finding out who's going to help you, what's your action plan going to be. Did that just close?
Yes.
Yeah. Oh, sorry. Okay. But that's okay. So at the end there, and there's the different printouts there. The final thing. Sorry, I just have to open that again. Does that stop sharing? Yeah. Just take you back to that very quickly to finish up. So I'll just whiz you through here just to familiarise yourself with the route in. And then the final plan is to start signposting people to people that might be able to support them. So ideas for you, things that you can arrange, and signposting different activities. So the CSP is a fantastic resource to help signpost local activities, county sports partnerships, rather than they're a CSP. But they have a wonderful collection, and we've tried to break down all the different things that are kind of a wonderful national organisations that people might be able to signpost to. So here, for instance, there's the community volunteering charity who connect people with the outdoors and others, and network activities around. So the support organisations, so for instance, we've been working with versus Arthritis, Osteoporosis Society, and various others to link to all of their support resources and things like that. So I would encourage you, please, to spend a little bit of time having a look around the website, and do use it in clinical practice, and let us know how you get on. We'd love to hear from you and how we can improve it, and hopefully it's a valuable resource. So thank you.
Well, I can see at least one person thinks it's a valuable resource, because there's someone posting in the chat box, wow, this is an amazing resource. Thank you, perfect. So that's great.
Well, that's great, thank you. Anonymous attendee, I told my mum not to come on the chat room, but that's
So, and everyone who is registered for the webinar will get an email afterwards, and we'll include a link to Moving Medicine website in that link, in that web email, so that you can take a look at it.
Thanks. And we're looking to develop a sort of ambassador network with that as well. So anyone who is keen in getting involved, we'd really love to hear from you and engage you with the project. So please send us an email and get in touch. That'd be wonderful.
Brilliant. And I'm hoping that one of the national organisations that you refer to on your site is Parkrun.
Yeah, so
I think
runs,
an awful lot of people are familiar with Parkrun, but people are possibly less familiar with the fact that Parkrun actually has MSK ambassadors to support people with musculoskeletal conditions to take part. So it's great to have Dr. Ai Lyn Tan, who is one of those ambassadors, on the line now to explain how Parkrun is trying to support people with musculoskeletal conditions to be more active.
Thank you, Sue. I'm going to try to share my slides. Brilliant. So, as Sue mentioned, I'm one of the 3 outreach ambassadors for arthritis and MSK conditions for Parkrun. My day job is rheumatologist in Leeds. So it's all very relevant. So I'm going to focus on Parkrun's role in how we can help with arthritis and MSK conditions. So I'm going to tell you about the best thing in life, really, which is free, it's timed, it's weekly, it's 5K. It's Parkrun. So just to put a bit of perspective to what Parkrun is for those who don't know about Parkrun. I'm going to go through what it is, and then I'm going to talk about some Parkrun health initiatives, particularly Parkrun practice. I'm going to be focusing on the project I'm involved in, which is Proof, and then I'm going to finish off with some cases of successes that we have seen through this project. So what is Parkrun? So it's a non-profit organization. It is weekly. It happens on Saturdays, 5K, and there's also a junior version on Sundays, which is 2K for those aged between 4 and 14. It is entirely organized by volunteers, so it's free to participate. People just need to register once on a website, and you can participate anywhere. And the benefit of registering is you get a personal barcode, which can be scanned at the end of participating in each Parkrun, and you get the time either emailed or texted to you. So just to put into perspective some staggering stats of how Parkrun has grown over the years. So these numbers are about UK's Parkrun. So to date, there's over 560 events just within UK alone, with 1.7 million taking part since 2004. Thousands and thousands every week, new registrants, runners, and volunteers. But this is not confined to UK. It's happening in over 20 countries in the whole world, with 240,000 weekly participants. So it's a really big phenomenon where everybody can participate. So one of the characteristics of Parkrun is it's open to all. It is free, so everybody's welcome. People are welcome to walk the 5K. They can obviously run it. If you want to do neither of walking or running, people are more than welcome to volunteer. No skills is required for volunteering. You can turn up, and volunteering training can be given on the spot. No one is made to do anything you're not comfortable with. So you can either volunteer, and if you don't want to volunteer, you can simply attend and spectate. So really, it's great to just turn up and be amongst other parkrunners. You don't even have to do anything. That's the beauty of it. One of the unique features of Parkrun is that people go there because of the community feel of Parkrun that has attracted so many. And because of that, Parkrun is no longer content to sit back and be reactive and want to be driver of change. So a few years ago, Parkrun came up with a mission to create a healthier and happier planet. So Parkrun is taking a proactive measure and considered steps to encourage participants, particularly from those who are least active, maybe because of long-term conditions, people from areas of social deprivation, etc. So one of the first things Parkrun did was to get a clearer picture of the participants, particularly the level of activity before they became a parkrunner. And also from their postcodes, we were able to link to indices of multiple deprivation so that we can have sort of a concerted, developed, strategic, targeted intervention to evaluate successes. Parkrun also paid attention to how it communicates to the public, both in terms of the language and the imagery used to reflect reality. Parkrun also made some operational enhancements, particularly providing tail walkers. These are volunteers who are people who would deliberately stay at the end of each parkrun, so nobody ever comes last other than the tail walker. There are also support for the visually impaired and the hard of hearing with sign language. Parkrun also have a group of volunteers who are outreach ambassadors who go out and try to seek out sort of communities who would be interested in participating in Parkrun. But what I'm going to focus on is the health initiatives, so particularly Parkrun practices, NHS 70, and long-term health conditions and disabilities, which I'm going to talk about a little bit more. Just going to show you some numbers as well, and these are the numbers of people who were previously inactive before they became parkrunners. And you can see that there is quite an increase in numbers over the years of such people who were previously inactive, which kind of reflects the success of the strategies that Parkrun has instituted. But what Parkrun is most delighted with is that the average parkrun time has become slower and slower each year, suggesting that there are more and more people walking at Parkrun, perhaps because the strategies are obviously working and it's become more inclusive. There are more new people who's never been active before, who's attempting to be more active. And I think this is quite striking. So here are some of the initiatives that have worked really well. So this year, Parkrun has collaborated with NHS 70th to celebrate NHS birthday and celebrated in June, just a month before the actual day itself. And on that particular day, there was a 14% increase in participants, 1,000 of whom rate themselves as being inactive prior to coming to their first Parkrun, with 37% increase in first timers. On the same month, Parkrun Practice Initiative was launched, and this was a partnership between Parkrun and the Royal College of GP, and this creates opportunities for GP surgeries to have a commitment to promote Parkrun. It is self-declared and guidance and toolkit are provided, but creativity is definitely encouraged. So there are lots of benefits of becoming a Parkrun practice, particularly improving health and well-being for practice staff as well as patients. Also to raise awareness of services that the practices provide, but also to develop local community centres around wellness. This also supports the growth of social prescribing across the UK. So what do the Parkrun practices actually have to do? Well, they are encouraged to walk the talk, so to become a Parkrunner themselves, but also to encourage family, friends, colleagues to take part. Signposting obviously is a key part of this, and also to share stories and case studies to encourage and inspire others to participate in Parkrun. But this is what I'm most excited to tell you about, which is the PROVE project. So what is PROVE? So PROVE is the project supported by the Department of Health. So Parkrun, running all volunteering for everyone. To date, there are 13 different groups of conditions within this particular project. Arthritis and MSK came about 6 months ago. So here's myself or some of the ambassadors. We have Frank, who is the PROVE project manager, and myself and Jonathan and Michelle, who are the 3 ambassadors for arthritis and MSK. So myself, a rheumatologist, and Jonathan and Michelle, both are patients with arthritis and MSK conditions. One of the first things we did was to set up a Facebook group, and this is a closed Facebook group provided for people with arthritis and MSK conditions who are either doing Parkrun or interested to find out a little bit more about Parkrun. So we have to date over 200 members. Not everybody has done Parkrun, which I think is very interesting because we would like to encourage people who've never done Parkrun to come into the group and talk to people and find out a little bit more about them. So it is a closed, supportive group and a very active group where everybody inspires everybody. So it's a very positive atmosphere. So the other things that we have also done in addition to help providing a support group for patients with arthritis and MSK conditions is to come up with some accessibility guidelines to Parkrun which is specific for arthritis and MSK conditions, to event pages for Parkrun. So some of these things are what we suggested to the event pages to put on their website. Information about whether they're parking bays with blue badge holders, is the course accessible from the car park, are there accessible toilets, and what time they're open, is the course suitable for wheelchairs, and is there somewhere to sit near the start and the finish? And these are just some of the guidelines that we provided. The other thing is we also have a very enthusiastic group of members, and we encourage everybody to blog about their conditions and how Parkrun has helped with them. And so this is Michelle, one of our ambassadors who has Ehlers-Danlos syndrome, and she has a blog on the Parkrun website. And these are just some of the things that she mentions about how she went through it. So Parkrun has helped through some difficult periods of ill health and recovery, whether it's walking, running, volunteering, or watching. Parkrun gives me a sense of achievement that enables me to socialize with others and meet new friends. There have been times, if it wasn't for Parkrun, I would have been totally isolated. Here is another member of our group, Shan, who has lupus, and on the website where she mentions her experience about Parkrun. So when a new Parkrun started locally, I decided I was going to take part. I will be honest and admit that pure anger got me wrong my first Parkrun. I was angry with myself and at my lupus for not allowing me to run any longer. But it was all quite positive due to its inclusive and community-rich nature. Parkrun has enhanced my life beyond words. I've made new friends in our Parkrun family. I've challenged myself and developed as a person, and my physical and mental health have improved. And this is right across all the people who shared the positive posts on the Facebook page. And then finally, here is Janet, who has ankylosing spondylitis, and she's been taking part in Parkrun for a number of years. And she says, despite my body hurting, I kept doing my weekly parkrun, which really helped. Everybody at Parkrun encourages everybody else, whatever age, gender, size, ability, because we all have running in common. Some weeks I would go and would be in so much pain I could only walk around the course, but it didn't matter. I was out in the fresh air, getting exercise, encouraging the fast runners as they overtook me, and being encouraged by them too. I always felt better for doing it, says Janet. And it's just such positive posts that makes it so encouraging to everybody else. So just to summarize, so Parkrun is for everyone. It's 5K. Well, welcome to walk, jog, run, volunteer, or simply just come along to watch. It happens every week on a Saturday morning, and there are over 550 UK locations. It's a great place to encourage patients to make friends, be part of a community, and as a result of that, improve health, be active, but also learn new skills from volunteering. So everyone is welcome. The best thing is it's free. Taking part is very easy. Simply register on the website. You get a personal barcode that can be used anywhere in the world where there is a parkrun, and literally just turn up. So you just never quite know what you're going to get in a parkrun. And just to finish off, how I would use this so I'm a rheumatologist. I see a lot of patients with arthritis and MS conditions. For anyone who's never heard of parkrun, and I thought they might enjoy and benefit from it, there are posters and leaflets from Parkrun that we can print out and give to patients, which I do, and simply direct them to the website. And what I normally do is encourage them to just go and watch and see what they think about it, because not everybody can run, not everybody can walk. Some people feel uncomfortable to simply volunteering. So turning up and watching to see what everybody else is doing may be the first step. So that's how I do that in my clinics. So thank you.
That's great. Thank you very much, Ai Lyn. And we will also include links in the email we send you afterwards to those articles that were shown. And do you want us to also circulate the link to the Facebook group in case people want to recommend that to patients? Okay, that's great. So we've got a little bit of time left to take a few questions. So the first one is going right back to the first presentation about CSP. How much have CSP engaged with the fitness, sports and charitable sectors, particularly exercise instructors who work with the community?
Say that, I didn't hear the last bit of that.
So how much have you worked with the fitness, sport and charitable sectors, exercise instructors? And there's also mentioned Sport England and Richmond charities. You've done lots of work about understanding the audience. Has all of that been?
So this was all, so this was all based on some of the research that came out from the Richmond group. So we are very much linked into them, and all the work that we're developing around community rehab is working with all the charities within that group. We're also currently working with, talking to Sport England about how we work together, because I think the important thing, and someone I think early on asked, what's this got to do with me? This is about, you know, a campaign for physios. And actually what it is it's very telling, and it applies to all of us. It's really what patients are actually saying, is that if you start the conversation with telling me the stuff I logically already know, because I know exercise is good for me, then they turn right off and they feel like the person doesn't get them. But if you start it from the point of view of what do you love doing? What did you love doing? What would you like to get back to? And then you bridge until you look at those resources that Moving Medicine have done, which really demonstrate the positive versus the negative. Then you can go back to the logical once you've got the person. I think Escape Pain is a really great example of how this works. So you need a professional at the start of that pathway to create the confidence and to reassure people that it's not going to make it worse, but it's actually going to make it better, even though it doesn't seem to make sense. Challenging that legacy of rest that Hamish talked about. And so we are talking also to UK Active. And so it's very clear there's a very important role for the wider exercise community. But I think the assessment and the beginning of that pathway and that rehab program being set out and also discharging a patient is where the professional can work. And then there's a whole host of things that can happen. And ultimately, the idea is where people can self-manage. That's what they move on to. And that's what's amazing about Parkrun, because it really has taken something that is like immediately people might sort of psychologically dismiss. It's running, it's for runners, it's for fit people. And they have totally turned it on its head. And actually, as part of the love activity, hate exercise sort of question mark sort of approach that we take, we are really signed up to this.
Great, thanks very much. Next question for Hamish, looking at the ambassadors link on the website, is there scope for practitioners in private practice to become ambassadors?
Yes, please. I saw that, Deborah. Thanks for your message. Yeah, I mean, we, in terms of a population health approach, clearly the focus is through the NHS and systems, but ultimately, we'd like to make this useful to people practicing in any form of clinical practice, really. So, yeah, please come and join in, and we'd love to hear from you wherever you work and whoever you talk to about physical activity. Yeah. Great.
And then question from James here about how much engagement there has been with the Scottish government. So brilliant presentations all, but how much engagement has there been with the Scottish government? They have launched 2 key public health strategies this year, and by the end of 2019 we'll have established Public Health Scotland, so there's lots of scope for influence here. Has anybody been engaging in Scotland?
Yeah, so there was a presentation that our Scottish policy manager did, and they asked for the campaign. We're a 4-nation, we represent all of the UK, and we have obviously also Welsh versions of the campaign in Welsh language, but in terms of Scotland, so very involved. And some people may know about the First Contact physios who are now in GP surgeries, and so the pilots have gone live in England, but actually there's a huge pilot that went live this year in Northern Ireland, and actually Wales is also ahead of the game, and Scotland as well. So we announced that, and that ties in heavily because when you go see a physio, an expert in this, and they start that conversation and then they do the onward referral, it's a quite important piece.
Thanks. And we have pretty much run out of time, but I'm just very quickly going to ask this last one, which is for Hamish, which is how does your resource relate to the Wales Deanery resource Motivate to Move?
Yeah, thanks, Ruth. And thanks for your other message as well. So Brian Johnson, who's been leading that, has been involved in our sort of advisory panel for moving medicine. For those of you that have visited his website, it's a very, very comprehensive resource that, outlining the evidence base and everything in physical activity. And one of the key things when we had the brief to develop this resource was that we didn't just reproduce things that were out there, because there's already such good resources available already. And so that's why you'll find that interacting with moving medicine is a very different experience to interacting with Motivate for Move as a website, because their objective is really is a different focus on the same objective, really, and I think that they're useful in different purposes. Our focus is specifically to support the clinical practice, really, and with perhaps a slightly different approach on the information. But if you're looking to get a sort of long form of the information and work through the detail, then that's clearly a wonderful resource to look at as well.
Great. Thank you very much. Thank you to all of our speakers. Thank you to Arthritis Action for supporting this webinar. And we will be circulating links to a number of the resources that have been mentioned in the webinar within the next day or so. So thank you very much.